Peace, peace, peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Riley. Peace, YouTube. We begin the new chapter. Here we go. Playing in the flowers. It's been a great day. Wish it's been a wonderful day for you as well. This is episode 56. All right, so here we go. Chapter 22, Principles of Ventilator Care. History. All right. Yeah, let's get into that. Consistently successful techniques for artificial ventilation were first developed in the 1920s in conjunction with anesthetic administration. These were positive pressure techniques that developed parallel with capabilities for endotracheal intubation. The development of ventilatory support outside the operating room simultaneously developed in a different direction, primarily because of the unavailability of endotracheal intubation, the desire to avoid tracheostomy, and the fact that the necessity for ready access to the patient's body was far less necessary than in the operating room. Therefore, the negative pressure ventilator, iron lung, gained enormous popularity. Applied almost exclusively to the polio victim, the iron lung provided reasonable support of ventilation without the necessity for tracheostomy or endotracheal intubation. The effectiveness of negative pressure ventilators came into serious question during the following World War II. The Scandinavian polio epidemics of the early 1950s clearly demonstrated that survival was better with positive pressure techniques. The superiority of the positive pressure ventilatory support was generally accepted, and the modern era of respiratory care begun. Over the past 30 years, it has remained true that the power capabilities of positive pressure machines far exceed those of negative pressure machines. And it has remained true that following the establishment of a secure airway, the positive pressure machinery can be placed a distance from the patient, allowing appropriate monitoring, therapy, and nursing care. However, it has never been true that the positive pressure ventilator is physiologically advantageous. To the contrary, the physiologic disadvantages are numerous. Peace, YouTube. Thank you for being here in the book reading live from the light here in LA. Bottom of page 326. We just started out on chapter 22. In this sixth section of this masterful book, Disadvantages of positive pressure ventilation, PPV. The disadvantages of positive pressure ventilation may be divided into two broad categories. One, problems related directly to increased airway pressures. And two, variance in the distribution of ventilation in relation to pulmonary perfusion. All right, here we go. This is figure 22.1. Classic airway pressure curves for various modes of intermittent positive pressure ventilation, IPPV, superimposed on the normal spontaneous airway pressure curves, IMV, or which equals intermittent mandatory ventilation, and IDV equals intermittent demand ventilation. So you'll see IPPV and the airway pressure, centimeters H2O in the vertical bar. And then the control mode, assist mode, the IMV, and IDV. And we'll go more into that as we thank you so much for being here and reading with us. Awesome. Peace, everyone. Make sure you get that. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And we are in the 22nd chapter. All right. Second edition, 1979. Thank you for the likes and subs. We're pushing towards 600 subs on this channel where we read books and learn from masters. So you see how it is in the control mode, assist mode, IMV, and IDV comparison to the IPPV. Increased airway pressures, top of page 328. When compared to the steps are not always linearly related and may vary quantitatively with pulmonary disease. The effect of positive pressure ventilation can be generalized as follows. The increased airway pressures result in increased intrathoracic pressures. This increase in intrathoracic pressure is potentially harmful to cardiovascular function since the return of venous blood to the right heart is dependent on the pressure gradient from the peripheral veins to the right atrium. Ding! Yes! To the right atrium. Yeah, I know y'all feel me out there. I see the lights. I know it. Yo, it's so deep. So deep. Oh my goodness. Since increased intrathoracic pressure leads to increased intraatrial pressure, the driving pressure from the extrathoracic veins to the atrium of the right heart is diminished. Figure 22.2. This phenomenon is known as a reduction in venous return and will be discussed in detail in chapters 26 and 27. Thus, increased airway pressures have a potential to cause a decrease in venous return, which may lead to a decrease in cardiac output. This is perhaps the greatest single detriment to placing patients on positive pressure ventilation. Yeah, right? It makes sense when we put it all together, right? That's why this is the master's corner of YouTube, you know. You have to be able to master thyself, master ourselves, then we can help others around us. You know, be that guiding light. Highest heart love. Thank you so much for reading books with us. Yes, we're in the 22nd chapter. It's incredible. All right. So, what we have here is figure 22-2, like they were saying. So, you'll see in a supinated position, okay, spontaneous breathing, and then with the PPV. Now, you'll see the positive pressure is coming from the top, right, and pushing down into the intrathoracic, like we were just speaking of. So, thank you so much for being here. Highest heart love. All right, here you go. Down at the bottom. See that? Excellent. Thank you so much. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. 1979, second edition, Yearbook Medical Publishers. All right. So it says Figure 22-2. Spontaneous ventilation provides optimal distribution of ventilation in relation to perfusion due to mechanics of the spontaneously contracting diaphragm. In addition, venous return is optimized because intra-abdominal and intracranial pressures are more positive than intrathoracic pressures. Positive pressure ventilation, PPV, results in greater air distribution to the non-gravity dependent portions of lung and potentially hinders venous return because intrathoracic pressure is more positive than intra-abdominal or intracranial pressure. Gratitude. Thank you for reading with us. Peace. Alahana. Mia Mia. All right. Bismillah. Distribution of pulmonary perfusion. Top of page 329. Distribution of pulmonary perfusion. The increased alveolar pressures resulting from positive pressure ventilation tend to favor pulmonary blood flow even more toward gravity dependent portions of lung than with normal alveolar pressures. This process potentially results in greater areas of lung being well ventilated but poorly perfused. Thus, positive pressure ventilation usually results in increased dead space ventilation, even when adequate cardiac output is maintained. Distribution of ventilation. The spontaneously breathing supine individual, see figure 22.2, demonstrates a relatively greater diaphragm excursion posteriorly than anteriorly. This is advantageous since posterior lung is better perfused than anterior lung in this position. With positive pressure inspiration, the diaphragm is essentially passive, and the tidal volume tends to distribute to areas of better compliance, i.e., distribution of ventilation is favored to the non gravity areas. This tendency for positive pressure inspiration in the supine position to result in increased aeration of anterior portions of lung makes dead space ventilation and physiologic shunting more prevalent than with spontaneous ventilation. These relationships are believed to be present in all positions, i.e., positive pressure ventilation tends to favor distribution of ventilation to non gravity dependent areas of lung. The above factors lead to a general clinical statement. It is physiologically advantageous to breathe spontaneously to whatever extent is consistent with maintenance of cardiopulmonary homeostasis. This providing augmented means of ventilation has recently provided a significant improvement in ventilator, ventilator care. Peace, peace, YouTube. Thank you so much for reading with us. Yes, clinical application of respiratory care. We are in the 22nd chapter, down at the bottom of page 329. And I will put the vocabulary in the description when it's complete uploading. Thank you for being here, especially if you don't understand, it's great for the vocabulary. I've gotten so much love for it. They say, I didn't understand this. Now I looked it up and I read with it, and it makes sense. So this is anatomy, highest level understandings. Like I said, when we master ourselves, we can heal ourselves. When we can heal ourselves, we can help heal others around us. That's the energy you're in right now. Ventilators are not respirators. The general classification of positive pressure ventilators has been presented in Chapter 3. It must be stressed that these machines are ventilators and not respirators. It has it in exclamation mark. And the machines do not ensure molecular gas exchange at the pulmonary level respiration. Rather, they provide movement of gases into and out of the pulmonary system, which is ventilation, right? Since true respirators are presently available, e.g., extracorporeal membrane oxygenators and heart-lung bypass machines, it becomes essential to realize that although it is traditionally acceptable to refer to ventilators as respirators, they are not truly respirators and provide only ventilatory support. Physiologic capabilities of IPP or PPV. It cannot be assumed that all patients in acute respiratory failure or acute respiratory insufficiency will benefit from mechanical support of ventilation. Only when physiologic respiration can be improved or maintained is it logical to consider application of positive pressure ventilation. Since the ventilator is a machine that only alters inspiratory airway pressures, a rationale for its application must be based upon delineating the conditions in which such airway pressure alteration may be physiologically advantageous. It may be generalized that a positive pressure ventilator may beneficially alter physiologic gas exchange by performing three tasks. Two, here we go. One, to provide the power to maintain physiologic ventilation. Two, to manipulate inspiratory airway pressures and flow patterns to improve distribution of ventilation. And three, to manipulate the ventilatory pattern to improve gas exchange. Yes. Power. Middle of page 330. Inspiration is a process requiring muscular energy oxygen consumption. When the ventilatory muscles are incapable of providing the needed power or doing so is detrimental to the organism, a ventilator can provide all or part of the required energy. Inspiratory flow pattern. Inspiratory flow patterns may have significant effect on the manner in which inspired gases distribute, especially in the presence of pulmonary disease. Modern ventilators have significant flexibility in altering inspiratory pressures and flow patterns. The most significant of these maneuvers appears to be the end inspiratory pause. See chapter 23. Ventilatory pattern. Inspiratory to expiratory ratios, ventilatory rate, and tidal volumes greatly affect respiration. Ventilators can partially or completely control or modify these factors. Oh, top of page 331. Ventilator commitment. Based on acceptance of generalizations stated to this point, it is reasonable to discuss the clinical rationale for placing a patient on a ventilator. A medicine and surgery increase their ability to cure and palliate disease. An increasing number of patients are becoming candidates for mechanical support of ventilation. Mortality and morbidity are believed to be significantly decreased when early commitment to ventilator support is initiated. Ventilator commitment is best avoided when that's unnecessary. However, if commitment is indicated, it is best instituted prior to cardiopulmonary collapse and resuscitation. Such early or semi elective commitment to ventilator support makes it incumbent upon the respiratory care practitioner to ensure that the procedure is performed in the safest manner possible. Ventilator care places a great responsibility on the physician and the respiratory care practitioner. The physician must accept the procedure as a complex and demanding commitment and create the milieu in which all health care personnel can provide the highest quality of care. The physician must be prepared to make whatever commitments are necessary and indicated. Halfway, ventilator care is worse than none. Ventilator care is never curative. It is a supportive technique that demands the presence of potentially reversible pathophysiology. The ventilator can accomplish no more than maintain cardiopulmonary homeostasis within acceptable physiologic limits for a period of time. It is a disservice to the patient, her or his family, and society to commit or continue the use of mechanical support of ventilation when disease reversibility is not possible. The recent sophistication and general acceptance of ventilator care have led to moral, religious, legal, and philosophic problems that must be dealt with by the entire healthcare delivery system and society. It is neither the intent nor the scope of this text to discuss these aspects of the subject. The authors simply wish to emphasize that all criteria and rationale for the institution and maintenance of ventilator care must be based on the clinical assertion that a potentially reversible disease process exists. Ooh! And that's where we'll pause, right at the bottom of page 331. Ooh, of clinical application of respiratory care. Wow. I love leaving off there. When we pick up with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading with us, all the book lovers community, all my friends and family, also all the book lovers and writers. Highest heart love. We had a wonderful day. We did another wonderful Your Healing session today, and his hand opened all the way up. It was unbelievable. Oh, so grateful. So grateful. It's so big. Breathing and stretching to the entire body. Pressure points to the hands and feet. You can go back on my channel and see it. Getting the blockages out. When I'm getting the blockages out of his hand, his left side, they're just crunching, 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 crunching. Ah. And he said to me today, he was like, Malaku was like, it's a pain. It hurts. He was like, but it's a good pain. When I asked him, and like you said, it was a pain. So I'll try and be a little bit more gentle, but I'm just so proud of you. And he was like, no, it's a good pain. It's amazing. But those are all little blockages in that, the pathology. This was how it works is our hands and bottoms of our feet, are literally roadmaps to our entire body, externally and internally, right? So heal the people. Did the grocery giveaway yesterday. Man, it was so tired. There's so much going on. Sending you love. That's why I come on here. I know to give you this peace. And like, man, I know a peaceful place on YouTube I can just go to. And I know that I'm going to listen to some good, beautiful information, right? Spread it by one of the great light workers on this planet. Give honor to all the light workers. We're doing it. We heal the people. We read to the people, educate the people. And I got the harmonic vibrational coming out soon. We have a meeting about that tomorrow as well. So we keep on shaking it up on YouTube, right? Super high level, make their heads hurt, make them uncomfortable, knowing that the masters are still masters. Thank you. Highest heart, love, and honor. I love you. I love you. And you know it. Because I love myself. Archangel energy. I see you. Nice. Thank you so much. Thank you for all your prayers. Remember, you go out, take your walk, look up, see what you see, what resonates with you, right? And know that you are a part of this big, loving universe that wants you to win. That's what I'm showing you. You want you to win. All right, so peace, peace. I'll see you soon. All right. I'll see you. Yeah, I'll make sure.